Hello. Okay. Testing. Okay. We're going to go ahead and get started. I realize that there's still people over there getting something to eat. Go ahead. Continue on. We just wanted to get started so that we could keep this as much on time as possible. We have a really tight schedule, and so we don't want to get behind by lunchtime. First, my name is Sharon Richardson. I am president of CCSVI Alliance. I'd also like to recognize Dr. Bill Code, and I don't know where Bill Code is. He's back here in the back. Bill Code and I were asked by the leadership of the ISNVD to organize this event, and so we appreciate all the support from the patients and also from the professional, the scientific community coming together. First, a little bit about logistics. I don't know whether you realize right outside the door here, if you go right across the hallway, are the restrooms. And you can get up. There's a water bank over here. Please feel free to get up during the time. If you feel like you need to stretch, get a glass of water, whatever. We'll try to do this as informal as we can. Again, I'd like to thank the ISNVD leadership for offering the opportunity for the patient community to come and meet and also to learn from the scientific professionals about the research which is now surrounding the vascular component to not only MS but to other neurological diseases. I think that we'll start out. Is Dr. Zamboni, where did he go? Do you want to come on up and then we'll get done? I would like, let me tell you too, on your program, on the inside are the bios of all of the speakers, and they are listed in order of their speaking, okay? So instead of me getting up and introducing and telling you who they are, please just refer to your program, and then that way it's going to save us some time. I would like to now introduce Dr. Robert Zvadinoff from the BNAC, his current president of the ISNVD.
So, good morning, everybody. Great to be here, and great that you find time to come to Orlando. So, ISNVD would like to welcome you. I think this is a special day for us and for you, hopefully, because we would like, to educate our patients respect to this problem, CCSVI. And clearly, throughout the day, I'm sure you are going to hear a lot of interesting presentations. Now, my question is, how I'm going to change the slides here, because I don't see the mouse, and I don't see the... So if you can put my slides on, here is... So, from the when CCSVI has been first time described by Professor Zamboni, I think a lot has been learned about the CCSVI. And so I would like to start this patient day with trying to provide you information about what we learned in these 2.5 to 3 years. So MS is a disease that clearly in the past has been attributed to autoimmune origin. It's a combination, there is no one causal factor, a combination of environmental factors, of which the most important are probably vitamin D insufficiency and smoking, infective factors, of which the most important is infection with Epstein-Barr virus, and genetic predisposition. As you know, there are now many genes that have been discovered to be of particular importance for increase of susceptibility of MS, have shown I think we are too far, probably. So environmental factors and genetic as well as infectious agents increase the predisposition for activation of T and B cells in MS. Now, in 2009, Professor Zamboni described this condition that clearly is based on the hypothesis and clearly later findings that there is impaired drainage in the patients with MS due to the outflow problems in the extracranial part of the venous system, mostly in the jugular veins and in the hemiazygous and azygous veins. Now, clearly, according to this problem, the patients with MS cannot drain the brain properly, and that may interact with the disease. So what we learned in the last 2 to 3 years is that a number of different imaging methods have now been proposed for monitoring and as well diagnosing this condition, including non-invasive ones, Doppler sonography, magnetic resonance venography, computerized tomography, as well as invasive ones, catheter venography and intraluminal ultrasound. Clearly, the ideal approach, which definitely is not practical, is to do multimodal imaging, but I think it will be necessary for this condition, in which you are doing a number of different methods that have ability to detect the same condition. And so in a study that we are doing in Buffalo called PREMISE, we are using 2 invasive and 3 non-invasive techniques to detect same problem, which is stenosis. So you can see here time of flight and tricks. These are without and with contrast MRI modalities, the Doppler, the computerized tomography, the intravenous ultrasound, and catheter venography. And when you do such approach and such a multimodal approach, and you find always the same problem, clearly you have very good confidence, I would say, that there is a stenosis there. Now, in the last 3 years, many studies have been published to support or not support the existence of the CCSVI. What you see in blue are positive studies, what you see in red are negative studies. Now, the first controversy is that most of the blue papers are published in radiological journals, and most of the red papers are published in the neurological journals without any scientific approach. You can deduct this from this slide. Now, there are some asterisks here, which one papers use multimodal, invasive, or invasive and non-invasive imaging, and you can see that only few papers, mostly from Professor Zamboni and our group, until now use the multimodal imaging approach. So I would clearly urge throughout the meeting and in the future all investigators to use multimodal invasive and non-invasive approaches for studying this problem. Now, what's the problem about? I think in the early days Professor Zamboni stated what's the problem about, but we went also a step further in a recent paper published in American Journal of Neuroradiology and looked for a number of these abnormalities, whether they are in the vein lumen or outside of the vein lumen. And so we classified all abnormalities in 3 groups: intraluminal, extraluminal, and functional. So one thing that seems pretty obvious now is that CCSVI is almost all about these findings that we can find in the lumen of the veins. I'm not going to bother you what they consist of, but they can be of different types that can be detected not only now by Doppler, but we have even recent pathological studies that are confirming the type of and description of these abnormalities. If you look this paper, we also provided definition. Now, are these abnormalities unique for MS patients only? The answer is no, because substantial number of healthy people also have these abnormalities. But certainly, MS patients have more of these abnormalities. So what are these abnormalities doing? They are probably altering the flow, creating the turbulence, and with the time, they may contribute to what we call stenosis. These are the extraluminal structural abnormalities that are impairing the lumen of the vein. They can be of two types, stenosis or annulus. And if you look how many patients have this problem, in at least this study, not so many, 25% of MS patients and 15% of the healthy controls. So clearly, having a stenosis is probably a very late end-stage phenomenon of, I would say, CCSVI. In this study, we are also saying that the best correlation we found was between these abnormalities and the creation of collateral veins. That means that if there is a flow disturbance, clearly the physiologic response is to create the alternate drainage, and that's why patients with MS have more of collaterals than healthy controls. Now, clearly this is creating a functional abnormality, which is a reflux, and other types of functional abnormalities. And finally, as I told you, creation of the collaterals. So I think that more studies are definitely needed to confirm these findings and the evolution of the CCSVI abnormalities over time. Now, clearly, the question that we need to pose ourselves is what is the origin of these abnormalities? Are they congenital? If so many healthy people have it, are they physiologic? Or they are acquired due to the aging, due to inflammation, due to some viruses, or in relation to flow abnormalities at periphery and in the central nervous system. Clearly, many studies will be needed to answer this question. In a recent review article, we kind of proposed several pathogenetic mechanisms that may predispose CCSVI, and it's clearly our very big interest and effort we are doing in Buffalo in trying to understand what are the risk factors for CCSVI in MS patients, in patients with other neurologic diseases, and in healthy controls. And you can see a number of different things. One is already has been described in the past, endothelial damage, which would activate inflammatory pathways and contribute to iron overload. The second one is perfusion damage and oxidative stress. I think it's a very important one, especially with respect to the treatment, because I strongly believe that the transitory improvements that we see in patients after treatment are related to reperfusion of the brain and better oxygen and better oxygen maintenance of the brain. The other thing is how many veins people lose with MS and how CCSVI relates to that. We are actively working on that, as well as of the role of cerebrospinal fluid flow and CCSVI. Clearly, our latest findings are most prominently suggesting that Epstein-Barr virus may be very, very connected with CCSVI, as we found in people who do not have MS, that history of infectious mononucleosis is one of the most important risk factors. Also, surprisingly, we are finding that healthy people who have CCSVI have more frequently irritable bowel syndrome. So our interest is expanding from the CNS to the bowel problem, in which clearly we would like to understand whether CCSVI might be connected with Crohn's disease, with irritable bowel syndrome and other and that makes sense, because if you think that the azygos is closed, the nearest region by is the bowel, right? It's the gut. So clearly, I think that amount of findings we are having may allow us to redesign this slide, in which we can put in conjunction to other risk factors, also CCSVI, to possibly contribute to abnormal immunologic response and higher susceptibility and most of all severity of the disease. And my final slide is some general consideration. So over the last couple of years, clearly there are a couple of questions to be answered. Does CCSVI exist, and is it unique to MS? We know now, I think, with great confidence that CCSVI exists and that is not unique to MS. Because people with other neurologic diseases have it too, and also healthy controls have it too. The question is how much you have it, and in our findings, there is no big distinction between MS patients and people with other neurologic diseases. That means that Parkinson patients have it too, people with neuromuscular diseases, people with neurovascular diseases. The question is then why all these people, especially with neurologic diseases, have it more frequently than, and I'm referring to some unpublished data that are going to come out of very group of OND patients that we now recruited in Buffalo. Second question is, what CCSVI represent? Is it a conditioned disease? We know now that there are specific symptoms that might improve when you reopen the veins, and this is headache, this is sleep disturbances, sensation of the brain fog, and fatigue. Whether all of these are connected with reperfusion is definitely to be demonstrated. What's the most sensitive tool for non-invasive and invasive diagnostics test? I think we are going to talk a lot about this during the meeting, but clearly the screening should be done by more than one diagnostic tool, so we are recommending both ultrasound and MRI for non-invasive screening, and I'm clearly advocating multimodal approach. Then if you have CCSVI, can you live with it and have no problems, or really this condition over time is going to alter your disease? And what about healthy people? They don't have it. What does that mean for them if they have the CCSVI? Is their outcome, and we don't even know which outcome, is going to be altered over 10, 15, 20 years? We need to answer these questions. And finally, is endovascular treatment needed? I am clearly said many times that I advocate only in this phase placebo-controlled trials, which will be able to demonstrate whether or not this treatment is needed. Clearly, many open-label vascular surgical interventions are conducted at the moment. We don't have a proven relevance whether this is going to help MS patients, and I think that we need to be very careful about this, especially with respect to the safety issues, and until we don't have techniques that can be adequately applied for permanently resolving this problem. And I know my time is off. I would like to discuss so much more all the questions I raised, but I will stop here. We will not take questions now or later. Thank you. Thank you. So Before I move from this stage, I would like to introduce Professor Zamboni. He clearly does not need a specific introduction, but it's always great pleasure to introduce Professor Zamboni, who we need to thank for this discovery and definitely for being, so energetic and so consistent and firm in putting this idea forward. Paolo.
Thank you, Robert, and good morning to everybody. I thank very much Robert because really addressed the future in his talk, and really I think that all the part he outlined in the presentation represents really the future of the research, and probably we are at the tip of a big iceberg in neurodegeneration. And so MS certainly was a mission model because we found in our exploration a consistent association between CCSVI and MS condition. But my talk is completely different. My talk is going to the past, is a history of research, and more of all, the history of the lesson we learned from the patient, because we understood the importance to investigate the venous system and the brain circulation from a venous side, thanks through the lesson we learned from our first patients. This is to go, okay. Okay. Ferrara is the place where we investigate CCSVI. It's a very, very ancient town. It's a small town. You may see there are the external wall, about 10 miles, external wall all around. And there is a big castle because it was the Duke, was like king of the town. And you may see the cathedral, and it's a nice place to live. This is a descent of the Duke of Este, of the head of the town, the Duke. And he was also a relative of the UK royal family. And Augustus Frederick Hanover, Duke of Este, risked to become King of England. But he was stricken by a strange condition. So it's very close to Ferrara history, really, this. A strange condition with no name at that time. This is the first page of his autobiography, is a diary, where he was objectively, he wrote the history of the disease. And later in the years, neurologists from UK recognized that this was the first medical description of MS. But at the time of Augustus was not a physician, there is no name. And the first page is very interesting. You may see, this is the first page describing MS, is written by hand, and Augustus traveled to Scotland for visiting a very close friend. But when he was in Scotland, the friend was tired. So he cried all the time. And after this, developed symptoms like optic neuritis. But the patient referred these strange symptoms to the cry, to the pain, to the sufferance for the relative who died. But this really was his first episode. So the Duke of Este subsequently, described the disease. This is a recent publication on neurology showing the classic natural history of MS. You may see any tip is a relapse, and when you have a steeper of a curve, you have a progression. But curiously, if you substitute the diary of Augusto to this is the iconography of Augustus at the Alberta Victoria Museum in London. You may see he born in 1794, first attack in Scotland, optic neuritis in 1822, as curiously, at that time, there is no definition of MS at all, no knowledge, no MRI, no interferon, no angioplasty, nothing. But the course is exactly the same. Exactly the same. It's very curious because you may read the diary. Unfortunately, I do not have an English version, but it's very interesting. So this is the story of my town. This is my university. This is the main stair. Distinguished students and professors, for example, Paracelsus, one of the more important physicians, Cananus, I show you because it's important, Niccolò Copernicus, etc. Professor Canani was the professor of anatomy here in Ferrara. At that time, the faculty was behind the church, but he was the physician of the Pope, so had the authority to perform the first autoptic studies. And in the post-mortem studies, he discovered the venous system, and he discovered the venous valves. So this is very interesting in this story. And this is my family. This is my wife Helena and Matilde. Very important members are Gattirelli, the black cat, and Paco is the dog. We live really close to the town, but in the country. And for personal reason, probably everybody knows, I was interested in MS because when my family was stricken by the disease, I was not capable to understand really nothing from recent papers. It was very mysterious and was completely inadequate in my family as for a physician, as for an husband, to answer the question in my family. So I decided to study. And I was also motivated by when I read this paper showing the natural history and the proportion of patients at the time where you have a possibility to develop important or significant disabilities. I tried to study and I found a lot of very interesting papers. And in 2002, really, I received an email signed by Franz Schelling. And Franz rapidly in the email asked me why I was not interested to perform valvuloplasty in the jugular vein valve. So, of course, I was unable for the reason. So I replied him, and in my mind I was very curious because nobody knew at that time that I am studying MS. And also, at the time, I was studying the relationship with the cerebral venous system and iron deposition, and I found this very interesting because it was an area of interest of my previous research, so I found this very interesting. But I asked, but why you are writing to me? And Franz told me, because I Googled venous valve and surgeon, and the first name I found in Google was Paolo Zamboni, so I decided to write you. Okay, so it's very interesting. So this was very interesting because really Franz collected a large amount of paper that cannot be downloaded by the usual system of a researcher, by internet or by PubMed or by the bank data of the journal. So he sent me by regular post a lot of interesting paper, and I learned very much from the material he showed me. And in 2007, we had the first meeting speaking of this. It was a little seminary in my university, and I invited Franz. He joined us in Ferrara. This is one of examples. This is a beautiful, really beautiful paper. It's more than a paper, it's like a book, the topography of lesion in multiple sclerosis that I had by Franz. And this had a little ticket. Dear Paolo, I hope that you may found what we are looking for in this paper and other fancy ladies. So we have a very good exchange, and it was really fantastic man. In 2002, I had a lot of patients, so I asked to the patient if they have some relative or someone who had MS to refer to me. And I had a very good response, so I found a lot of people who are interested to be investigated by duplex. And in September 29, I found the first reflux. This is the picture of the first patient with a reflux in the jugular vein. And I was not capable to understand why, because this happened during regular respiration, during regular breathing, this phenomenon. The cross-sectional area was very high, so there is no evidence of stenosis, but with the probe that I have available at that time, was not capable to explore the supraclavicular fossa very well. But my first hypothesis was a compression from bone, something like this. And I tried to understand if other people may have this kind of reflux. So this is some example during that year. So for 3 years, I passed time to investigate patients. I found a lot of abnormalities respect to students, residents that I used as comparison. Really, I found clearly abnormalities in my first learning curve in about 35% of people, so not so large amount, but was unbelievable abnormalities. So I was very curious, and I did not find some abnormalities in my residence, so I was really very interested in this. But the problem that at that time I was not capable to have a good protocol or qualitative protocol because I did not find nothing in the literature. So I tried to start again from the beginning. I tried to give a physiological rule to duplex as an exploratory system of postural and respiratory controls of venous return. And this was done, of course, in little space in my surgical activity or my activity as a vascular specialist. So it required a lot of years. But in the meantime, I had the possibility to perform some autoptic studies. This was very important because this is probably one of the more important lessons learned from patients who died from MS. And I have the possibility to explore the vein. And I began to understand that probably was not something like a compression of the bone or what at the beginning I hypothesized that could be the reason of the abnormalities. And I found this very strange septum and malformed valve and something that may disturb the flow in the veins, because the veins is a very low regimen pressure, so it's different philosophy of blood circulation with respect to the artery. And so I found something like this, and I tried to improve the ultrasounds in order to demonstrate what I learned in the autoptic room. And also have the possibility to perform some histology in the brain at the microcirculatory and capillary level, and I found many of the things that was described by the authors who my friend Franz sent me the paper. And curiously, I found a very interesting correlation between chronic venous disorders and the legs with chronic and the patient with CCSVI and MS. So you may see iron deposition, fibrin calf, some inflammatory cells that are called macrophage, who may phagocyte, everything is wrong in the tissue. For example, this macrophage taking up iron in the MS plaque. So, and I simply proposed at the Royal Society of Medicine in 2006 a parallel from a histological point of view between chronic venous disorder in the legs and probably some chronic venous disorder in the brain. And at that lecture, probably Marian Simke and other people in the room were introduced to the CCSVI concept in 2006. We developed a quality protocol that have a main problem of the quality protocol is the operator dependency. So this make run, as Robert Zivadinov showed, sometimes the data not comparable because it depends too much by the operator. This is a catheter venography because, as Robert Zivadinov suggested, certainly this is a very complex disease and probably there is no just one imaging system as a gold standard. Probably we need of screening methodology and to have a multi-modalities to investigate the patients. This is very important also for treatment program, and there is a lot of people now, this is fantastic really, that are working on this, and like Mark Hackey and other that which have a contact and a fantastic replay in active term, investigation, other people involved and interested. You may see the philosophy of CCSVI by comparing the tube of healthy control, imagined by catheter venography, and the presence of stenosis that you may see easily with the red arrow, and collateral circulation that try to bypass the obstacles and to permit a good return of blood from the brain to the heart. This is the first valgus case we treated on December 11, 2006. You may see a complete obstruction of the valgus vein, and this is the effect of the treatment. The treatment was done for the first time by Dr. Galeotti. This is not mentioned never enough because of my shadow. I really like to have him as a speaker because this is really a very good job of Roberto. And 2 days later, we performed the first balloon angioplasty procedure on the left internal jugular vein. This was on December 13, 2006. And starting from this observation, we investigated less than 10 patients, and finally I decided to perform a pilot study under IRB approval to understand better my ultrasound pre-op findings and catheter venography, and possibly the effect of a very conservative and safe treatment like angioplasty is. And so 2007 we have the IRB approval, and between 2008 and 2009 publication of the first seminal papers. But it's very important we established an interdisciplinary cooperation. Because my point from the beginning was to have in my team not just interventional radiologists and vascular surgeon, but it's very important to involve the neurologist. This can be very tough at the beginning. We need to have patience, to speak, to have exchange, and to have patience and to try to involve. This is, I think, a key. This is team at work at the beginning, you may see, but really, this was my first relationship with neurologists. And my question every time was, but why Dr. Salvi is always so angry? So this is an official, okay, it's not our official picture, but always with food. Big lobster. So this is the second slide, is when we are performing the first blinded study. So we were compelled to not see the patient before. So we arrive exactly in the neurological hospital. It's about 40 kilometers south from my university in Bologna, but with cakes and other, not only Doppler. And look at the third, there is a pizza in his right hand. So he is really always angry. This is the Mingazzini. In the first patients we operated during a relapse phase. So this is an hemiparesis. This was a relapse. This happened May 23, and 2 days later you may see that the Mingazzini was certainly improved. Why I decided to show you to the patient this? Because there is a big difference when you are looking to internet movie regarding the effect of the treatment between acute relapse and chronic disability. Really are two different things. Sometimes I suppose that many of the unbelievable miracles, there is no miracle, believe me, are in consequence of the phase where the treatment is performed. So if you should be in a relapse phase or in progression with relapse, certainly you may have an improvement by immediate reperfusion or by lowering the pressure, better perfusion, reduce the edema. This is very important as anti-inflammatory tool. And so sometimes you have really an interesting reversion of the symptoms of a disability you develop. If you should have disability accumulated for 20, 30 years, cannot be the same, because there is a remodeling of the tissue that does not permit to have a recovery, for example, of axonal transection. This cannot be possible. May possibly you have some area of remyelination, something interesting may happen, may certainly happen because probably this is not exclusive to MS, so you may have better quality of life simply because you may improve very important symptoms addressed by Robert Zivadimov in the talk, So less fatigue, this means that you may have a better rehabilitation, for example, because otherwise you do not have the strength to have a good rehabilitation program. You have less fatigue, you are better cognitive function, good relationship. You may probably regain some of the recent disabilities, but there are no miracles. This is a part of medicine. And also, we may understand better and better if there are any other possible therapeutical target agent that are related to the circulatory function. This is very important. However, this was a very important lesson learned, because if you should have a so rapid response between symptom and treatment, certainly I had the awareness, and also Dr. Salvi, that there was a relationship very clear in the etiopathogenetic, very complex etiopathogenesis of this disease, between the presence of extracranial obstruction and the presence of the neurodegenerative disorder, because this probably can be also addressed in a proper randomized control trial. So one trial can be treated by usual high dosage steroids, and the second arm can be treated by PTA, by venous angioplasty, without any steroid treatment, because we performed 18 treatments in this condition, and the results were amazing. But you have to remember that we are speaking of relapse, not of chronic disability. It's something completely different, because with proper treatment, the same disability can be regained in the majority of cases in 20, 30 days. So this was really unbelievable, because in less than 24 hours, or sometimes less than 2 days, you have a complete recovery. So this was really amazing experience. But believe me, do not understand to everything is shown in the internet, because I suspect that many of these miracles are treatment performed in relapse phase. Okay? I spoke of this in London at the Charing Cross. It's a very important meeting for vascular people, and I met several years later, like in the book of Dumas, 20 years later, I met again Mike Dake, where he had his residency in interventional radiology in the same hospital where I was trained for vascular, and he was very interested in my talk, and it was fantastic, because 3 weeks later he called me that the first treatment in the US was done in Stanford. So this was amazing. And some months later we organized the first CCSVI meeting, inviting a lot of neurologists, especially Robert Zivadin, who was the first neurologist interested in research in this field in the United States, from a high reputation hospital, high reputation neurological team with Bianca Weinstein-Gutman and everybody. So this was the first group. Of course, there was a lot of people that you may know, and from that moment started the research. This is very, very, very important. This was the results of our first pilot study. We were capable to demonstrate with respect to the previous period a reduced relapse, an increased rate of relapse-free patients, a reduction of active lesion at MRI. We improved the performance measured with multiple sclerosis functional composite. That is the graph that you may see. MSFC, functional composite, is practically an index, a number, that may integrate motor function of the upper and lower extremity and cognitive function in just a unique parameter. And you may see that you have a significant increase that is maintained in the group over the time. We improve the quality of life and especially the chronic fatigue. But this study has a lot of limitations. You have to remember this, and we need to be honest in admitting this, because there are no control group, but we need to start from somewhere. No randomization and no blinded clinical assessment. It was the same neurologist who performed the pre-op assessment who performed the post-op. So our clinical results were considered to be affected by the placebo effect, by the neurological community, in the absence of a sham arm and blinded assessment. And this was written in a lot of paper. Venous angioplasty and fatigue is really amazing. So we finally hypothesized that chronic fatigue could be a symptom of CCSVI independently from the presence of multiple sclerosis or not. For example, in patients who underwent to hemodialysis, it's very common to find jugular stenosis because had a lot of puncture in the jugular veins. We have a connective reaction and a stenosis, and curiously, those patients experienced chronic fatigue. So this is very important. This is the placebo effect long-lasting? These are 29 patients with relapsing remitting. Any point you may see is a patient, and the second point is the outcome 2 years later. So it's 4 years observation. And you may see the annual relapse rate and the EDSS, disability score, is significantly improved, but this is nothing. Look at the point. There are 4 points, and so this represents 4 faces for me and 4 patients who did not have any improvement. So when you have to read a paper, you have to understand that we are expressing this in statistical sense, not individual sense. So on average, we have an improvement. It's not an improvement, in my opinion. This means something very important for a chronic disease. It's major stability. Stability, not progression. Less relapse, and no disability accumulation. This is fantastic. But remember, 4 on 29 did not have these results. Probably CCSVI is not a so important point to be treated for that patient. So we need also to understand this. Really, there's a lot of work to do. Okay, I'm finishing. Okay. So the answer is probably these ongoing clinical trials. There are clinical trials. One is Brave Dreams, is in Italy. I am the pleasure to say you that our regional government allocated 3 million euros for this double-blinded sham, and this is, I think, very, very important. Thank you very much.
Okay, we're going to change the schedule just a little bit. Dr. Hockey is going to come up, and then Angela Lagasse, do you want to come on up onto the podium so that we have you up here? Okay, good. One of the other things is I forgot to mention, some of you may not realize that we have this being televised. Actually, there's people on a webinar right now all over the world that are listening to this. So welcome to those that are listening on the webinar. And you should have a chat column over to the side of your computer. And if you have questions that we will try to address at the end of the day. Okay?
Thank you very much, Sharon. And Paulo, thank you for a most interesting historical lesson. It's just a fascinating story there. So I'm going to talk to you a little bit today about protocols in MR applied to CCSVI. And I won't spend too long on some of these because I'm going to try to get us on track here. Next slide, please. Of course, there's always a lot of contributions from many people, and I'd like to acknowledge the students and postdocs and faculty who have all contributed. MR can do a lot of things in evaluating neurological, neurodegenerative, neurovascular diseases. Of course, in MS, we tend to look for white matter lesions, and you can see very nicely that in MR, we can collect this type of data in 3 dimensions. So we get pretty much the whole brain slice by slice, sometimes pretty thin slices, only 1 or 2 millimeters, and this is very important information for the neurologists. We can do another approach, it's called T1 imaging, that we do pre and post contrast. This is also very high resolution, 1 cubic millimeter, and the reason that this is done is not only to look at the structures clearly, but to also look at lesions pre and post contrast, and you can see here that post contrast, that contrast agent has leaked out of the blood and it's got into an area where the blood-brain barrier has broken down. And this is usually an indication of an acute lesion. The chronic lesions will appear dark here. So it's a good marker too in terms of if there's any activity there. One can also compare those type of images, both T1 and T2, with the SWI images for iron content. And here you can actually see this region, this boundary region here has high iron right here and also over here. And so we can begin to evaluate what's happening in the lesions quite different than a contrast agent. This iron may represent a breakdown of the tissue. It may be more of a biomarker of the problems that are taking place. It's not clear to me that iron is necessarily a source of the problem. But we do see some very interesting biomarkers for iron. We see iron buildup in the globus pallidus here and even the head of the caudate. We can see it in the pulvinar thalamus. And the interesting thing about that is that we see this in about 50% of the MS patients. And there'll be a presentation during this meeting by Charbel Habib in our group that shows if one looks at 3 standard deviations of iron content, that you only see these type of abnormalities in about 1% of normal people. So it's a clear indication in MS that something is wrong. But you can do a lot more with MR. You can actually study the blood flow to the brain in terms of perfusion. And perfusion is important because that's the oxygen delivery to the brain. And here again you can see the usual type of flare in T1 images on the left. And then on the right, in these colored images, you can actually pull out which of these lesions, being acute or chronic, have a certain amount of blood flow or blood volume associated with them. And this chart on the right shows what the normal measurements for white matter would be. And then this single point here right beside it is the CBV, or blood volume, in an acute lesion. So you can see that the blood volume has gone up. And this actually agrees with work done on cadaver brains 100 years ago in Europe that demonstrated this same point. But all these other small points here that follow after that, that's the CBV in the chronic lesions. There is significant reduction in the cerebral blood volume in those chronic lesions. Now with MR, of course, you can image the vessels, and there's been a lot of talk about that with CCSVI. We can see the arteries very clearly, of course, in 3 dimensions. And Paolo, I hope you'll see here that some of these early discoveries you made in 2D or partly 3D in one vessel, we're getting close to being able to do in the entire head, neck, and heart in 3 dimensions, and eventually doing flow quantification every 40 or 50 milliseconds. So we can get a complete vascular fluid dynamic structure of the head, neck, and heart. Now this is the next image that comes with a dynamic contrast enhanced scanning, and here you can see now the veins very clearly shown. So again, you get this whole three-dimensional picture. This is applied directly to an MS case, and this is a method called 2D time of flight. And the banding that you see on the right-hand side represents the fact that there is reduced blood flow in those jugulars. But the anatomy pictures are not really good enough, because you can have something that looks absolutely normal but has no flow in it. That's the problem with using something like a contrast agent to visualize the blood vessels. So here, just to show you that if you narrow in on that previous image, you can highlight specific vessels of interest like the anterior jugular veins. You can focus in on the vertebral plexus itself, which is beautifully shown in the left-hand image. You can look at the deep cervical veins on the right-hand image. So you can really study the entire structure here while you're doing this. And I agree with what Robert said. It's very important that we look at these multimodalities so you can overlay the ultrasound with the MR or your PTA and angiography with the MR. All of these things are very important. Of course, as we go into some MS studies, you can now see an example here with the presence of collaterals here in the left side because you have a string stenosis. Here you see the same thing on the right side where you have a lot of collaterals and you have a very long string stenosis, so the presence of collaterals are also useful information. And there are many types of variations I won't go into today. All of these are different MS patients with different types of problems. So I'll go back to this example of the banding. The banding here with 2D time of flight usually represents the fact that we have very slow or even reverse flow, reflux flow, which is what creates that banding. And here is a flow quantification for that case, and I'll draw your attention to the bottom left graph. And you can see in the blue here, the blue represents reflux. It's flow in the direction of the arteries. And it's not just a small amount of reflux, it's significant reflux over about 50% of the cardiac cycle, and it's in both the jugular veins. And so this is in good agreement with how we would have interpreted that data. We can also go and measure flow in the CSF. I'm not sure how clearly this will show, but the third image right here, you see the bright. The bright is representing flow in the CSF during part of the cardiac cycle, and the dark representing the flow in the second half of the cardiac cycle. So the integrated flow in one heartbeat is roughly 0 here. And you can get a lot of interesting information from the CSF. And there was a paper, I think, published recently by Chen and Demadian suggesting that you do have problems in the spine and you do have CSF flow problems. And there are several posters here and some presentation. I think Robert Zvadanoff will also talk about CSF. And there appears to be a tight normal range of flow in CSF. And flow outside of that may be abnormal. So this is another parameter that can be measured. So why perform MR imaging? Well, it's important to monitor the lesions, to monitor the flow, to be able to get 3D vascular data as a form of interventional planning, to categorize the different types of MS populations. And I'll come back to that in the last few slides. And to make meaningful correlations between what we see pre- and post-treatment, and finally to track these changes over time. So MR, I think, should be an integral part of any of these. So I'm going to close just with 2 or 3 slides to say why is CCSVI important. I think the problem and difficulty with MS has been there's so many variants that we have seen that it's kind of hard to believe that one of these is a cause or an association of MS. And it's true, there are just many, many different types. So I'm going to show you a study here that we did with Haibo Xu in Wuhan. And this is a study of 29 patients, and again, thanks to the students for processing. And 18 of these 29 patients show the same pattern. And that pattern is we see sometimes no left transverse sinus. We see significantly reduced flow in the jugulars on the left side. And the interesting picture is the bottom left here. The bottom left, you see the jugular, there's no transverse sinus at all. You actually have the stump of the jugular at the top, and you have multiple vessels from the brain coming down and feeding into that stump. So this is very interesting. And I can show you 16 more pictures, and they all look the same as this. This is a very strong marker for CCSVI. I just show you 2 more here, and highlight, notice there's only one major vessel carrying the flow out of the brain here. It's the right internal jugular. almost no flow from the other vessels. So CCSVI actually is quite prominent in Parkinson's disease. And this leads credence and credibility to everything we've talked about in multiple sclerosis, that the presence of these abnormal flows has a strong association with the disease. So I think we're still very close to the beginning in trying to understand the whole characterization process, and then taking this the next step. Are these really treatable? Which parts of the multiple sclerosis abnormal spectrum can be treated where we would expect good results, and which ones may not be treatable? And I think that's where we are today, and we're looking forward to many interesting presentations at the meeting today. Thank you very much.
Thank you, Dr. Harkey. Okay, Angela Lagasse is going to be our next speaker, and she's going to be talking about some imaging. Angela?
Thank you. I don't know what he's going to do. Just waiting for my... I don't know. Oh, yeah. You going to teach me here?
Yes.
This one? Here we go. So I was asked to speak also about... Oh, this is the wrong one. Oh. Maybe you can just do this, eh? There we go. So I was, as I was saying, asked to speak about establishing protocols with regards to the ultrasound Doppler. I've kind of taken a little bit of a different approach than Dr. Hakey, but I'm the first person to follow physicians, so bear with me. Our protocol that we have established in Barrie, myself and Dr. McDonald, we actually had, when Dr. Zamboni had first been on the news and CTV and all over the world about it, was back in November of 2009. So Dr. McDonald and I put our heads together and did a lot of research and sort of were going through things on our own, and then got the chance to go and meet Dr. Zamboni and work with him and his colleagues in his laboratory in Italy, which was wonderful. We've actually been there a couple of times now and have been able to reestablish what we're doing in Barrie to sort of mirror and adopt what Dr. Zamboni was doing in Italy. Basically, as far as the technique and whatnot goes, it's important that the anatomy is understood. The J1, J2, J3, this is, of course, from ultrasound perspective. So this is a very important thing that we need to establish, because this is where your cross-sectional measurements are taken, and it's important to realize that. So that's first and foremost is the anatomy and what's happening from that. I'm sort of just going through the criteria a little bit here. The first criteria being the jugular, and of course the vertebral reflex as well. My example is jugular. On the well, I guess, yeah, that's the left-hand side of the screen. It is what a normal jugular vein should behave. And on the right side is a classic example of reflux in the jugular vein, lasting, well, more than 0.88, actually up to almost 2 seconds, we've seen as well. So that's the first criteria. Second criteria is a little bit different. The deep cerebral reflex. This is something that is another method that is being done outside of having the QDP application that they're using in Italy and some other labs in the United States as well. But as you'll notice, the spectral analysis on the bottom actually represents the same that you would see even if you did have the QDP. It's just missing the vertical component on the left-hand side. So the image on the left would be normal, sort of inspiration, expiration. You're getting that spectral waveform, and it is identical and symmetrical. And on the right-hand side of the screen, on inspiration, you'll see one, and on expiration, it actually disappears. That as well sometimes is also inverted. On inspiration, there'll be nothing, and on expiration, you'll see something. We see that quite often as well. So this is again, it's different. It's outside of the QDP, but Dr. Zamboni is actually aware of this and was fine with it as well. So The third criteria being B-mode abnormality, on the left you'll see there's a normal jugular vein with no B-mode or no valvular dysfunction that I could find. On the right-hand side, you will see there is actually a valve that stretches right across the whole vessel, creating a septum. So this would be an example of a B-mode abnormality. The fourth criteria, of course, block or no flow detected. Again, on the left side being a normal jugular vein, and on the right, a complete lack of flow there. So that would indicate that that jugular is blocked. Again, for a period of at least 0.88, but again, up to and including 1.5 to 2 seconds long without any flow whatsoever. The fifth criteria in this image, I'm sorry about the images, they didn't transfer very well, and I did it so you could see them, but this is the cross-sectional area in the fifth criteria. This is a patient in the supine position, which is 0 degrees. You'll see where do I point? That right there is the jugular vein, that small little piece right there. And of course the carotid artery here. And this is in the supine position. So the measurement there, I think, I can't see it, but it's small. And this is what it is doing when the patient is actually at 90 degrees or sitting straight up. So it's significantly larger right there. So again, an abnormal finding. So I think as far as other factors go with establishing protocols is, there's some talk of ultrasound machines, what needs to be used, what doesn't need to be used. The probes are very important. A linear probe, of course, for the extracranial assessment of the jugular, as well as the slight curvature for the proximal portion into the fossa, as Dr. Zamboni referred to as well. And then the transcranial probe is important for the deep cerebral assessment. The patient's a pretty big part of this. Positioning is very important. Limitations and restrictions. Oftentimes patients are in wheelchairs. They are quite disabled, so oftentimes they can't transfer. If they don't have the ability or a chair that actually leans back into the sort of supine position, you kind of come across that limitation a little bit. We try our best to get around it, but that's something that you need to consider as well when deciding what to do when you come across that. Information and education for patients is a really big deal. I think the internet, as good as it is, can also be very dangerous. As Dr. Zamboni said as well, with patients on there with anecdotal sort of before and after, also with ultrasound and protocols that are out there, a lot of people are putting them on the internet and actually they have no idea what they're even talking about. So leads me to my next and last slide is training. Familiarization with the CCSVI criteria by Doppler ultrasound and importance of sonographer training is, I can't stress enough how important that is. We see often patients that come in and have been scanned in other facilities, and wow. So it's crazy what they even think, and I don't know where they get their information, but it's just something to be aware of if you're wanting to do that. Training and knowing the protocol is very, very important. And that's it. Thank you.
Okay. I'm going to call Dr. Jerry up. And Dr. Hewitt? Okay, do you want to come on up to the podium, and then we'll have you, and Bill Code, do you want to come on? And then we'll have you all here. Okay. The next speaker is Dr. Jerry Niedzwiecki. I hope I said that right. We're going to call him Dr. Jerry. Everybody here in Tampa, or around Florida, just calls him Dr. Jerry. I think we'll just use that. So thank you very much for joining us.
Thank you. I very much appreciate the opportunity to come and speak with you all. This is a very esteemed, world-renowned faculty, and I feel very honored to be able to be here. I am going to be talking at a very basic level. What I was charged to do is introduce many of you to some things that you may have not encountered, which is basically, how is this procedure done? What are you going to experience as a patient when you go through this process? Some of you have already done this, and if I'm saying something that's wrong, please speak up and tell me that I'm way off base. And that at the end of this, I'm going to do a very cursory literature review and try to put into perspective some of the things that are going on, because payment decisions are being made around the world, in Canada, the United States, regarding the status of the literature. And maybe it will help you understand what we are up against and trying to accomplish. I'm the economics chairman at the Society of Interventional Radiology, and I watch this very, very closely, and we try to really intervene as quickly as possible to be patient advocates. So that being said, let's start out with this. My office is called AI3, Advanced Imaging and Interventional Institute. This is the office just outside of Tampa. It is one of the first freestanding centers in the United States. I started this center about 7 years ago, and we've been doing CCSVI for a while. Now, we have tried to develop a patient and family experience. I don't know if many of you caught this. It was very subtle when Dr. Zamboni was talking. He said, when MS affected our family. Right? This is a disease process that not only affects the patient, but the family. And that became very, very clear to us very quickly. And what we really try to establish at our center is an overall experience for the patient and the family, which are who are traveling very long distances, which is more comfortable for them. So this is specifically why we do this. Here is the family of our patients who have come in, traveled long distances, and they feel very tired, out of place, out of home, and we're trying to make things comfortable for them. So we've developed the CCSVI Family Lounge for patients. And you can see we've tried to make it a very comfortable, homey environment, so they're not having to sit downstairs in a cramped waiting room, waiting around while their family members are being treated. You can see they've got an area to sit around and chat, and we've actually got in the back some books and jigsaw puzzles, and my wife was actually instrumental in that. She's sitting in the back there. She said, it's really nice to sit around with the family and make jigsaw puzzles, and it's just a nice way to talk. It's a pleasant experience we try to give for patients and their family. Now, let's switch gears a little bit. When you're going to be making decisions about where you want to have this procedure done, you may not think of these things. But all of centers have different ways that they approach this disease process. And you can have a C-arm, which is fixed, or you can have a mobile C-arm, which is going to be moved around. Now, I'm not going to say anything bad about a mobile C-arm. They're perfectly capable of doing this, and they do a very, very good job. My own personal opinion is I have a fixed C-arm because I want a lot of horsepower. To Italy, we want a Ferrari. We want a lot of horsepower in our imaging to make sure that we can actually accomplish what we want to accomplish. And it also gives us the ability to do 3D spins and 3D acquisitions and try to move this process forward in correlation with MR imaging and ultrasound imaging. So, when you are a patient, what are you going to experience? This is basically the procedure in a nutshell. It is a standard catheterization procedure for any interventional radiologist or endovascular physician. The patient is laying on their back. You're going to receive some mild sedation or some twilight sleep, as it's usually called. Your right groin is cleaned, and a very tiny quarter-inch nick is made in the skin in the groin. Quite frankly, after the procedure is done a week later, you're never going to be able to even see where we went in for this procedure. We place a catheter, which is like a long, thin straw, into the groin, into the vein in the groin, the right femoral vein. And then we use the veins as kind of a highway system. We're going to guide the catheter up just above the heart into the superior vena cava. And we are going to use one of the catheters to selectively catheterize the azygous vein, and then the right jugular vein and the left jugular vein. And we are going to take pictures of those. And then based upon what we see, we will then go ahead and either put in an angioplasty balloon and stretch an area, or we may not intervene at all. Once angiography and venography is completed and angioplasty is completed, we take the catheter out, hold a little bit of pressure in the groin, and you go to the recovery area and you lay still for a period of time, 1 or 2 hours, and you'll be able to then move back and get into your, wherever you're staying, if you're staying at a hotel or back home. So this is actually one of our patients recently. You can see they're laying on the table, sterilely draped. And these are the catheters that we use. And you can see here's this H1 catheter and a sheath and guide wires that we use. And there is the catheter in the groin. Again, you can see a very small nick in the skin, very bloodless procedure. And these are the types of images that we see. Can you run the MPEG, please? And this is something very typical that we see, and you talk about some of the imaging that you're seeing on the MR, where you see this cross-filling. We're in the left jugular vein, and you can see the flow is around the back of the head and down the right jugular vein. And can we go to the next slide and show the next slide, please? I'm sorry, one back. Yes. And here, once again, you can see very similar, this flow down with the stenosis down in the base of the jugular vein here. And that's what we're going to go after to try to intervene on. So how do we intervene? We basically take a angioplasty balloon, and this is what they look like when they're collapsed, and this is what they look like when they're inflated. We stretch the area, deflate the balloon, take it out, and we will then take additional pictures. And here you can see pre and post areas of stenosis or fibrotic valves that are overcome to improve the flow down the veins. Now, I didn't bring all MPEG files or movie files for you because it just would take a little too long to go through all of those, but you can see here what the pre and post imaging looks like for most of these patients. So, we can accomplish this procedure, and it is a very comfortable procedure for patients to have done. But are we making a difference? Are we making a difference? So if you look at the literature and you go to the PubMed site, which is the National Repository of Medical Literature, and you search these various topics, CCSVI, CCSVI and treatment, or angioplasty and stent, you'll see that the total number of publications to date, if you search CCSVI, is 71. For CCSVI and treatment is 26 papers. Angioplasty, 22 papers. 5 papers on stents. And quite frankly, if you look at the CCSVI literature, those 71 papers, a lot of those are the criticisms of it, as we had seen this polarization within the neurologic literature and the interventional radiologic literature or endovascular literature. Here are the 22 articles about CCSVI and angioplasty. Many of these are commentaries, not actually studies that have been done to demonstrate efficacy or safety of the procedure. When you further look in these 22 articles, there are 3 articles, 3, on the safety of CCSVI and angioplasty. And those are the 3 articles. Well over 1,000 patients have been studied and reported upon in the literature about the safety. And you can see all of the authors agree that this is a safe procedure. Major complication rates are in the 1% range, and all complications are in the 6% range, and that includes a little bit of bleeding or bruising in the groin. We put all of our patients on anticoagulants after this procedure so you can get a little bit of bruising. So it's an extremely safe procedure, and the article that was just published in 2012 showed that actually 51% of their patients were done in the office setting, outside of the hospital setting. And again, an extremely safe procedure in that setting. Now, if we look at effectiveness literature, okay, there are only 4 articles in the literature talking about the effectiveness of angioplasty for CCSVI, a total of 120 patients. And a majority of that literature actually comes from the gentleman at my right here, Dr. Zamboni, talking about the effectiveness of this. We honestly need to have more literature. If you look at these numbers, you can somewhat understand why, when these issues are brought forth to government officials, people on the nay side saying there's not enough data to support this, when they say there's only 120 patients reported on, it's hard for us to convince government payers to say, let's endorse this, okay? So, in conclusion, if you're looking at this procedure, it is clearly an outpatient procedure, and it is a safe procedure in the office or hospital. All right? The literature clearly shows that. There's no doubt in my mind. However, the literature regarding efficacy is fairly limited at this time. And there's a lot of debate, a polarization that has occurred, because the initial questions that came out were, does CCSVI cause MS? And there's a lot of compelling information about that, but maybe we need to take a step back. And is that the best question that we should be tackling right now in the early stage of this? And I think what you are starting to hear is what I'm suggesting here, is the medical community, the neurologists and the endovascular specialists, need to sort of come around this and say, are we making a difference in patients' symptoms? Okay? Are we doing something that is good for patients, short term and long term? And if we can come to agreement on that, the rest of it will fall into place for us. Is this affecting MS? Is this affecting Parkinson's disease? Is it a cause-effect relationship? But honestly speaking, you as a patient, what do you care about? You care about what's happening to your symptoms. And so that's my own personal bias. Thank you very much.
Okay, thank you, Dr. Jerry. And as a patient myself and president of the CCSVI Alliance, and I think Bill Code would agree with this too, that any patients out there that, if you have not had the treatment, you need to learn from Dr. Jerry, from the doctors, that this is why we're having this symposium, is so that you can learn about this and that you can advocate for your own treatment and your own health. So please, yeah, that's what you need to do. You got to be in control of what you're having done to your body. The next one is Dr. Joseph Hewitt, and he's going to be talking about treatment and outcomes. Thank you.
All right. You'll have to forgive me if I sound a little bit like Darth Vader today. I went up to Canada to speak with Parliament, and I don't think some of them liked what I had to say, so they gave me a cold. I'd like to speak with you very briefly about CCSVI treatment and follow-up. I've coined this optimal patient outcomes. The cartoon on the right says, let's give it another go the next time with a better follow-through, the guy with the wrecking ball. I think very appropriately Dr. Zavadnov and Dr. Zamboni have talked about a multimodality approach to imaging patients. I would expand on that a little bit by saying that we feel it's very important, as I think most people do, to evaluate people with a multimodality approach, but also treat them with a multidisciplinary approach. In some ways, there's a lot of focus, I think, put on the treatment itself, which I think is very important. But I'll echo what Dr. Zavadnov said last night, that a lot of the progress, I think, in the field and a lot of the legitimacy that I think we're going to achieve is going to be done through basic science. Being able to really identify those patients where the procedure will work best on, being able to stratify patients for their risk, being able to stratify patients for the effectiveness of the treatment, rather than just throwing treatments at people and hoping they'll get better. The diagnostics that we employ, ultrasound, MRI, and of course clinical evaluation. In terms of the treatment, I'd like to talk a little bit about jugular interventions, azygous interventions, and some of the interventions that have been talked about recently. Follow-up imaging, I think a term I like to use with patients is actionable information. What use is getting a follow-up imaging study unless it changes how you're going to practice, unless it changes what you're going to do to the patient? We can do this with MRI and CT and some other modalities. Follow-up would also include things like physical therapy, craniofacial interventions, anticoagulation. Of course, I feel that research is an important part of follow-up, because if we're not learning from what we do, we're only doing it 50%, in my opinion. So first of all, an integral part of our treatment process is using the MRI to get a good idea of what we're looking at in a number of mechanisms: general treatment planning, arterial assessment, looking at venous abnormalities, and setting a baseline for a lot of the measures we want to look at in the patient's future before we treat. Yep. So I got to show you the nice rotating picture. Well, I guess it won't go now. Let's try it again. All right. Isn't that pretty? Yeah, everybody, ooh, yeah. So, you know, all kidding aside, it's very useful to have a three-dimensional mapping of the veins before we go in there. It just makes for a safer procedure. It allows us to plan what we're going to do. What I tell patients who come to see us is, you know, if you had a map, it would be a lot easier to drive across Los Angeles if you had a map before you went than trying to go at it blind. It also influences how we practice. You know, there is some question of evaluating arterial structures along when we evaluate the venous structures, I've looked at 500 of our Heike MRIs. I've looked at the MRA, which is what you're seeing on the right, and I've found 0% incidence of arterial abnormality in 500 randomly performed MRAs on all of our patients. I think when you weigh this against the 1 in 100 risk of stroke for all catheter-based angiography, carotid angiography, that we really need to question the need for an indication for catheter-based arterial assessment in CCSVI patients. And this is how the diagnostics and the treatment really go together in our practice. Now, we use what's called time-resolved 3D contrast-enhanced MRV, which is a fancy way of saying, let's put some contrast in the blood vessels, watch them go up through the arteries and come down through the veins. And we can see it progress on your left from an MRA, early venous phase and late venous phase. And the red box, I'll expand on that a little bit. What I want you to notice there is how right at the bottom there's an area that's bright white, and this is indicative of a valvular abnormality. And this is really how, in terms of treatment, the diagnostics are very important. They can guide what we're going to do. I put red lines there to show you what the presumptive valvular abnormality and the differential and contrast enhancement is due to the abnormality. Now, as several others have showed you, including Dr. Heike before, we now can corroborate some of our suspicions with what's called 2D time-of-flight imaging. Basically, the imaging you saw before was by putting contrast in your veins. Now all we're doing is we're actually measuring the flow and we're making a picture out of it. We're taking numbers and making a picture, okay? But you'll see where that red arrow is, right down there. You'll see how it tapers and it narrows into a jet-like phenomenon. So now we have functional, numeric-based evidence that our picture may show us something that's important. So on your left, the flow-based anatomy. On the right, the imaging anatomy. A little bit magnified so you can see it better, and you can see how both of them taper. Also important, we acquire actual numerical data before the intervention. If we're going to attempt to move this procedure and this science forward, it's important that we acquire numerical data. Not only can we show, for instance, here we have a large amount of reflux. Sorry about that, Jerry. Large amount of reflux is blue line as it goes below zero. Now we have something to document, something that 2-3 years from now we can say, well, what is this person's flow like in their jugular vein compared to before when they had the treatment? So you have the contrast-enhanced version, you have a picture, you have numerical flow analysis, and then you go and do the procedure. And it all fits together really well. You have a reason for doing what you're doing. Evidence-based medicine. As part of the integration of multiple modalities, we can also use, for instance, MRI in our treatment algorithm to guide other tertiary things that we can use during the intervention. For instance, if you'll take a look on your left side, the red box surrounds the bottom of the jugular vein, and you'll see a small wedge-shaped defect there at the valve. So this is a late phase venous evaluation where we see a wedge-shaped defect at the valve, which makes us suspect, again, there's valvular pathology. The V shows the valvular pathology. At this point, we can say, well, let's take the IVUS and let's take a little bit better look at what this valvular pathology is. Let me go back for just a second. You can see a faint white line here. And this is an IVUS done by my partner, Dr. Rada. And it forms a type of windsock funneling the contrast through this area. And in this case, it's important in our practice. The MRI can help guide the judicious use of IVUS in certain types of patients. And of course, then we can do the angiogram and see how it's verified. Moving right along, azygous interventions. It's nice to be able to talk to patients beforehand about whether or not they may need a certain type of azygous intervention. Using 2D time of flight data, again, we can see areas that could possibly be narrowed on an oblique sagittal image. If we were to take a bologna slicer and cut you, you'd get axial images, and between the heart and the spine, we see some narrowing of the azygous vein. And another movie for you. The azygous vein in 3 dimensions, in some ways, extremely useful prior to going into angiography. We can get a three-dimensional look at how the azygos really is, collateral veins, connections, and really help guide our intervention. And once again, always going back to why are we doing what we're doing? Let's acquire some data, some useful numerical evidence. An azygos flow in this case, which is quite low, approximately 0.3 milliliters per second. Most people, you probably want to see something above 2. If you see 4, that's very nice. And of course, then we go to intervention, and here we can see lots of collaterals and obstructed azygos vein, and after the intervention, a very healthy flow with the absence of collateral vasculature. Just mentioning a couple other interventions, I know a lot of patients come into our office asking about May-Thurner syndrome, compression of the left common iliac vein by the right common iliac artery. And I'm going to get up on my soapbox and once again say that there is no evidence of increased incidence of May-Thurner syndrome in CCSVI as reported by a very good study out of Albany. Occasionally, when we do find a patient who has a history of deep vein thrombosis in their left leg or a history of asymmetric swelling in their left leg, we may find a May-Thurner syndrome. And here's the IVC, the big pipe in the bottom of your abdomen. And here's the pipe that goes down the left leg, and that pipe is blocked after some angioplasty and some stenting. The flow is returned to normal. Another topic recently has been the question of renal vein abnormalities. Are abnormalities of the renal veins associated with CCSVI? Personally, I don't believe it's true. I think it may be a case of what we in medicine call true but unrelated. As it turns out, about 15% of women 18 to 50 have what's called pelvic venous congestion syndrome. And I think the preponderance of MS in women, this may just be an overlap of the two. We use MR in our practice, again, integrating the multimodality diagnostics to get a good look at what the renal veins are prior to intervention. Some more movies for you. This is, again, Dr. Arata working his magic. On your left side, you can see a video pointed out to you. Here's the renal vein. It's trying to get over to the big pipe over here, the IVC. And here it's obstructed, and it's, of course, going into paraspinous, paravertebral collateral veins. So-called nutcracker syndrome. Nutcracker syndrome when the left renal vein is between two big arteries. Essentially, it's just being pinched. On your right side, you'll see after angioplasty and stent placement was performed, and it's probably useful to mention at this point that this can only be done with a stent. When you have something so-called pinching that vein, angioplasting it probably won't work because it'll just come back down again. Of course, ultrasound is a very important part of multimodality assessment and follow-up with patients. Immediately after the procedure, an ultrasound is a very useful tool for confirming patency and confirming normality in the patient's veins. It also helps reassure patients, help them feel better that there's no thrombosis that is formed, that flow is optimized. In our practice, we like to use, as part of our follow-up, imaging follow-up. I like to tell patients that 2 or 3 years down the line after a procedure, you may have some question about your status. And rather than having someone put a catheter inside you and go through the procedure again, wouldn't it be nice to just pop in an MRI or get an ultrasound, get an idea where you're at, rather than worry about these sort of things, right? You can see this patient over time had tracked, this is prior to intervention. There's the right jugular, the left jugular. You can see it's narrow on the bottom. The middle picture, you can see that the valvular abnormality is resolved, but you can see that after intervention on the left jugular, over time it actually gets worse, okay? And so in this case, we may ask ourselves, is there any point of re-intervening? I would say maybe not. If that person doesn't have a very good left jugular and the right jugular valve is open, this may be about as good as it's going to get. Pictures are also corroborated well by numbers. And again, I'll reiterate this. It's nice to have these numbers down, in fact, to about 1/10 of a milliliter per second, where we can say, for Bill Smith, on January of 2011, his jugular venous flow was 5.6 milliliters per second, and now at the exact same level, not dependent on a person, not dependent on the day, not dependent on the phase of the moon, it's dependent on the MRI only, that jugular venous flow is now X. And we can tell the difference and make useful clinical interpolations based on that. Just quickly, perfusion imaging, as Dr. Zavadnov had mentioned, will be a very important part of our practice going forward. We're doing a study right now where we're looking at perfusion, essentially how much oxygen, how much food is being used by the brain of the patient. How much is used beforehand, before the treatment? How much is used after the treatment? Is there a difference? CSF imaging. Does it change over time? We want to be able to quantitate iron over time in the patient's lesions and the deep white matter. Look at different types of MRI imaging to look at how the neurons are working. And finally, I'll just finish up here by showing an example of some adjunctive imaging. This is a jugular vein. You see some narrowing at the top here, some collateralization. And we can see when we correlated the MRI on the right to the CT on the left, we see some narrowing of what I like to call the cervical mandibular space. It's the distance between the mandible and the lateral mass of the cervical spine where the jugular vein is often narrowed in many patients. And you can see the jugular vein being narrowed beside that lateral mass. So there's a lot of other things that can be talked about in terms of follow-up, and we're going to hear more about that later on today, anticoagulation, physician follow-up, etc. And again, I'd just like to say in conclusion that as far as we're concerned, and I think a lot of the people who treat patients with CCSVI are concerned, that really getting the most out of this is going to involve a multimodality imaging and assessment approach and a multidisciplinary follow-up. Thank you. One other thing, I would encourage all of you to go home to your family, friends, and colleagues, and please ask them to join the ISNVD. This is really the sounding board for where a lot of the basic science is going to push this procedure and the ideas here forward, and we need everybody's support. So please go home and show your support for the ISNVD. Thank you.
Thank you very much, Dr. Hewitt. Next, we're going to have Bill Code, and then we're going to change things up after Bill Code gets finished with, I hope, a lively debate, and I'm sure that Dr. Sclafani is going to make it lively for us. So.
Thank you, Sharon. Welcome, everyone. It's been a delight to have such a tremendous input and response from my medical and other professional colleagues to organize this meeting, so I thank them from the bottom of my heart. I'm delighted also to have some of my colleagues here today from the Board of Directors of the National CCSVI Society. That's sort of the Canadian equivalent of CCSVI Alliance here in the United States. And I can't help but describe our logo because it leads into the concept of hypoperfusion. You've heard a lot of pieces today. My goal is to maybe try and put it in a patient's perspective. My background, of course, is anesthesiology and neuroscience research, but of course I've had MS myself for coming up 16 years. So the red of the N and the S demonstrates, the same as my tie, the bright red oxygenated blood that leaves the heart. The heart has just received the blood back from the lungs, and it is bright red. It now goes up to our brain through the carotid arteries and a few other arteries, but primarily through the carotid. And in a normal individual, it spends a small amount of time, goes through the capillaries of the brain and spinal cord, is collected by the veins back to the heart. And that would, in a normal individual, demonstrate that dark red that you will see in the center, the so-called C of NCS. However, if you have CCSVI, or chronic cerebrospinal venous insufficiency, because I know we've got people at all stages here today, if you have that, there's enough evidence now to suggest that there's a delay in that transit time, and it is quite prolonged. Consequently, in some of us, that oxygen is probably much darker, or there is much more oxygen extracted from the blood. So instead of being dark red going back to the heart, it's more of a dark blue, which would designate the ribbon through the NCS. So that will help you understand perhaps one of the premises of why some of us, including myself, have brain fog, is that the oxygen is not appearing well enough, often enough, quickly enough, because it's not getting there as fresh as it need get there. It's a bit of an oversimplification perhaps, but I think it has its place, and that's what I would suggest would be piece of the hypoperfusion of the brain. Now that's a term coined by Bernie Yerlink, Dr. Bernie Yerlink, who's a really excellent basic scientist and who's very keen on this area. We're lucky enough to have him on our board as well, but he's known to many of the scientists in the audience too. So that gets us started. You've pretty well had all of this basis. It was a superb outline by Dr. Zavadnov. I just wanted to put in a couple of points to clear up for the uninitiated. IVUS, of course, stands for intravascular ultrasound, so you'll now know what that means. So it's ultrasound, very much as was very elegantly outlined by Angela Lagasse, okay? But it's now done through the catheter inside the blood vessel, IVUS, intravascular ultrasound. The other piece that you may have missed in the go-round is that the azygos and the hemiazygos, which are lower down, of course, we're unable to look at with ultrasound. Those were required to use the other modalities, such as the MRI and the, of course, venography injection of dye. Okay? We cannot see those vessels with ultrasound. And that's something we don't all appreciate and realize, but it's very much the case. The other important thing to talk about is not all MRIs are equal. Almost everyone in this room, if they're a patient, has had an MRI. Fair enough. But unless you've had an MRI with cardiac gating, which can now time the MRI pictures with the beat of the heart, you do not have near the information, as has been well described very eloquently, by Dr. Hewitt and Dr. Hakey and others. Okay? That cardiac gating, it's near and dear to my heart as an anesthesiologist, of course, because it's done with a pulse oximeter, a little clip on your fingertip. Pulse oximeters, easy item these days, probably $500 or less. You could have one in your own home if you wanted to. However, if you're going to put it in the room with the MRI, now it costs $250,000. All right? But that's the truth. But you must have cardiac gating of the MRI if you're going to have a useful modality as far as looking at flow. These single imaging, and I confess that we've done a lot of them up in Canada in recent so-called studies of just simple MRI for blood flow in the veins, are a waste of time. Pardon my frankness. Okay, why treat it? Well, it's all about circulation. I don't think there's anything there to assist with symptom control and assist recovery. It's quite profound what it does for many people. There's one of my colleagues has followed 125 patients now. She has MS herself. She works in Quebec as a physician, and she feels 119 of them have had some benefit. What I want to address partly, though, and it's one of the elephants in the room today, we haven't talked about it at all, is the issue of recurrence of symptoms. Okay? I'll call it slippage, for lack of a better word, and I've been there myself. I'm now 15 months out from my single-only treatment of angioplasty, and I, like my sister, had both veins treated in the jugular veins as well as the azygos. We're both fortunate. We were wise enough to go to Buffalo for really excellent imaging and assessment by neurologists, and I was lucky enough to talk to Dr. Zavadnov probably coming up 2 years ago. But, my sister noticed changes probably 6 months out, and I noticed some of mine starting to happen at 8 months out. And some people are noticing it 1 month out, 3 months out, 2 years out, and some are noticing no changes at all. But we have to talk about this elephant in the room, because fixing the anatomical problem is not the whole deal. It's a big piece of the issue, but until we start to understand some of those other issues, we're not going to be there. So what is hypoperfusion? Well, reduced blood flow, arterial, and I keep asking Dr. Hewitt and others, is there any arterial problems? Of course, we do have arterial problems, we know, in some selected individuals. And we do know, one of my backgrounds was in stroke research, certainly if you have CCSVI, you are more vulnerable to stroke. That would make sense to me if you're going to block off an artery to an area and you've already got relative flow issues in that area because of problems with relatively blocked veins, you're going to do very poorly with stroke. So that's one piece. The other one I haven't included there, of course, you've got venous, but is cerebral spinal fluid. And CSF is now the big piece of the mix. It's just starting to come in, and we're going to be hearing more about it today. And if you don't have adequate perfusion, of course, you get reduced supply of oxygen and reduced supply of nutrients. Symptoms will improve. These were pretty well outlined by some of the previous speakers. I want to talk just a fraction about autonomic control, the temperature change, the bladder, and the bowel. And it was well stated earlier by Dr. Zavadinov, many of us with MS or CCSVI symptoms have irritable bowel symptoms. I'm there, okay? I never had the constipation problems because I had all the diarrhea problems from the other one, okay? And some of us are like that. Why do they fit together? And why did it all go away when I had my veins treated, including my azygos vein? So that's a piece, the muscle spasticity and the balance, those are harder to figure out. And sleep disturbance, well, sleep is a very nebulous item, but it's a very troubling item for huge numbers of North Americans and everybody on the planet. And many of us go down the slippery slope of medication because we can't solve our sleep issues. And, like many others, mine started to be a problem again. So potential causes I've already alluded to: anatomy, low blood pressure. When you're working as an anesthesiologist, you want to make sure that your patient, Mr. Smith, can remember Aunt Mary because he had an Aunt Mary when he went to sleep. You would like him to remember Aunt Mary when he woke up. Or you haven't done your job. And that's your goal, so you avoid low blood pressure. Stroke and all of its variants thereof. And I think there is bigger tie-in than we've started to think about it. And then I want to bring a new element in, which has been a little bit alluded to: thickened blood or hypercoagulation. Some of you in this room will have heard of anticardiolipin antibodies, which would be the American name. In Britain, it's well described by Dr. Hughes, a rheumatologist. It's present probably in 30 to 40% of people with lupus, and it's present in a modest number of the population, maybe 2, maybe 3%. There's a few hints of it. Okay? Another one that we have thickened blood issues would be Leyden factor. Leyden factor we've known about since about the 80s. It's maybe 3 or 4% of the regular population. It's 15% in Sweden. It and another factor similarly has its forebearer in a European white person. Okay? So those of us of that extraction, including myself, are more likely to fit into this category. We may have relatively thickened blood. You all know about extra thin blood. You've heard of maybe certainly hemophilia. You've heard of von Willebrand's disease, Christmas disease, and so on. But we must remember the thickened blood. There's probably a continuum. Not everybody with thickened blood gets a clot in their leg or to their lung or whatever. There is probably a thickened element too, and that's the piece I want to address and bring in today. I'm just going to put in one piece there. I want to talk about anticoagulation, and briefly, how are we going to address that? And the other is the old 30-year-old drug which has been used to reduce intraocular or inside the eye pressure, acetazolamide, or otherwise known as Diamox. I've probably been using it 8 months myself, and we've got a paper or a poster that we're going to present in the next few days, myself in conjunction with Dr. Dresler of Texas. Prevention of restenosis, I don't think there's anything new and different here. I want to mention nitric oxide enhancement. It's always good. Exercise is good. Special enzymes, that may be a bigger clue than we thought. Magnesium. And then about the anticoagulation piece. We're going to have disagreement in this room, but that's what spice of life is. Not everybody's going to certainly be put on warfarin. Warfarin's probably the #1 killer in North America as far as medications, because it's got a very narrow therapeutic window. It causes lots of bleeds inside the brain. I'm not a big fan of it. I think a more common one now is Pradaxa or Pradex, as it's called in Canada, or dabigatran. Some people suggest the veins are not well treated and served with Plavix. And so the protocol that I talk about is on behalf of Dr. Danielle Robitaille. She's a brilliant woman. She's the one that's followed 125 people, but she's also the individual who has MS herself and is quite challenged in her work role and is unable to come to meetings as a consequence often. So that's her protocol. Some clinics have adopted one like this and some have not. And that's a point of discussion that eventually will come to the room, because with all of our other silos now meeting in the same room, the neurologists, the interventional radiologists, and the vascular surgeons, you know, the imaging people, but we need to have a hematologist in board as well. And I think that the only other tie-in, we had the very elegant slide by Dr. Zavadinov of all the other causes factor, change it. We may have that genetic piece of thickened blood, but it can also be triggered by Epstein-Barr, some of the herpes viruses, things like chlamydia or mycoplasma or major infection, heavy metals, or even chemicals exposure. So it may be part of the environmental tie-in that we hadn't thought about, and I want us to put that piece together. So we're going to go on from there. I want to leave time for the other speakers. We can start to assess these. There's a 5-piece blood test. Short term for it is ISAC, and how are we going to treat it, and what's the modality to use. And I think that's only the other tie-in is vascular dementia is a very, very big piece of dementia, and the forerunner could well be vascular for the issue of Alzheimer's as well, and that's why we're here. I'm here too because I'm still frightened of dementia myself, 10 or 15% risk with MS. By words of Bruce Trapp, who spoke eloquently from the Cleveland Clinic last year in Bologna, Italy. Thank you.